Welcome to With All Due Respect. This is a podcast for women over 40 who are looking for sane, frank advice about their health and wellness, especially through and after menopause. I'm Amanda Thebe, a personal trainer and nutrition coach, and the author of the best-selling book, Menopocalypse, How I Learned to Thrive During Menopause and How You Can Too. I'd love you to join me every week as I chew the fat with some fab guests on hot topics that directly impact you. I also know the power of conversation is lost, and there's nothing better than sitting down for a natter with your mate and putting the world to rights. And that's exactly what I'll be doing with this podcast. We'll really get to know my guests, warts and all. I've made it my mission to help you by exploding a few myths and presenting you with plain, simple facts. These inspiring conversations will hopefully empower you to be a healthy, strong, resilient bitch, just like me. Before we get started, don't forget to hit subscribe and leave a review, and then visit me at amandathebe.com. And now let's get started on today's show. Hi, everyone. Welcome to the very first episode of With All Due Respect. I'm so happy to be back doing the podcast. I had a podcast previously called Fit and Chips Chats, and it was really popular and I really enjoyed doing it. But honestly, at the time, 2 years ago, something just had to give and I ended up stopping the podcast. But I'm in a different place now and I'm ready to start again. And I have some amazing guests lined up for this new show. And what I want to try and achieve with the new podcast is real conversations with people that I admire, people that have influenced me and my way of thinking. And so I've grabbed them all together and we're going to get talking over the next 12 weeks. So I am absolutely thrilled that today my very first guest is someone who has become a dear friend to me over the past couple of years. And she has took the time out of her really busy schedule to join us today. Dr. Annice Mukherjee is a top UK hormone specialist, speaker, and author with almost 3 decades of experience in hospital medicine. Her specialism is hormones from the early days and has always focused on optimizing quality of life in relation to hormone problems. Annice currently works full-time as a consultant endocrinologist in the private sector and was an NHS Consultant at Salford Royal Hospital Trust until 2019, having worked in the NHS for 27 years. Her medical knowledge helped her hugely when she went through an early menopause due to a cancer diagnosis in 2011. Annice is the author of The Complete Guide to the Menopause. I highly recommend it. I love it. It's one of the books I often recommend to women, as well as my own, of course. And that was published by Penguin Random House in January 2021. I think our books came out at the same time, didn't they, Annice? Welcome to the show, by the way. Welcome.
Thank you. Thank you so much for having me on and for the introduction.
Yeah, I think our books did come out at the same time, right?
Yeah, I think very similar time. I'd definitely seen yours. I didn't know you at that time, actually, I don't think, before your book was out, but I'd seen your book. So I think we were very similar and very similar, approach. And of course, we're both experts and we both know what we're doing. So I think we're on the same page with what's needed.
Well, when I read your book, even the words you used, considering the fact we hadn't ever met before, it was like, am I reading my own book here? It was so great to see so many areas aligned. And I don't consider myself an expert. I definitely consider myself like a patient advocate and someone who knows fitness and nutrition very well. You're an expert. And that's one of the things that I get a little bit frustrated about in our world. Everyone's become an expert. Have you noticed? And really, there aren't many experts out there, right? Who to trust is one of the hard things. But truly, you are an expert in hormones. So can you tell me why you started working in that area to start with?
So I specialise in hospital medicine, which is basically looking at all of the different parts of the body in a lot of detail. A lot of people don't really understand what hospital medicine is. They know about what surgeons are and what surgeons specialise in, and they know about GPs, but hospital physicians are kind of the surgeon equivalent of somebody who you go to when you've got really complex problems, basically. And that's what I specialised in. And so you have to go through all of the different specialties. So most people have heard of heart specialists, lung specialists, stomach specialists, brain specialists, joint and bone specialists. So there's all different specialists. So I trained through all of those specialties. So I got expertise in all of those, had to do lots of very specialist exams. And then after a few years, you have to decide which specialty you want to sort of super specialize in. And a lot of people at that stage, not so much now, but we used to always then go and do research in that area. And actually, endocrinology and diabetes was the last specialty that I specialized in before I had to make a decision on which one I wanted to do. And I just loved it. And I'd done cardiology, I'd done rheumatology and neurology, respiratory medicine, gastroenterology. I'd done all the different specialties, and it just set me on fire. I just found it really, really interesting. And I thought, this is what I want to spend my life doing. I love, all the different organs. It's so varied. It's so complex and diverse. You look after people with hormone problems right the way from, if you're an adult specialist, from puberty right the way through to old age. You look after people often for many years, which is, I think, a real advantage in that a surgeon will see somebody, look after them, while they're getting their knee fixed, and then never see them again. Whereas with hormone problems often stay with you sort of lifelong, depending on what they are. There's lots of different hormone problems. And so I've looked after patients over many years, managing and helping them manage their hormone related problems. So it ticked every box that I loved and enjoyed, really. And that was why I went into it. And of course, as I've specialized, done research, I've had a particular interest in quality of life, optimizing well-being, managing fatigue, which is a common symptom in hormone-related problems. And then I've just sort of metamorphosized into specializing more and more in women's health and hormone problems in women throughout the life, but particularly sort of perimenopause and menopause in more recent years. But I've always...
you've always, and to me, it's insane because hormones are so incredibly complex. I wouldn't even pretend to understand the complexity of them. I understand how some of them cascade and work alongside others, but I truly don't understand the depth of them. Yet you'd think on Instagram, everyone was a hormone specialist. It's it must drive you nuts, but especially I think in the menopause phase, because you have just explained that you understand hormones from birth to death, essentially. You understand the whole spectrum. And we have menopause specialists specifically talking about estrogen, progesterone, and now testosterone as, the main players in women's health, when we know it's so much more than that. And do you get a little bit frustrated in the narrow focus on just those hormones instead of looking at everything? And I suppose the question I'm really asking there is, do you get frustrated that we're solely focused on the hormones we lose rather than the potential of the hormones, that we have, and the availability of lifestyle impacts that, support those hormones?
Yeah, absolutely. I mean, we do focus on a very small number of hormones when we're talking about menopause. And yet those hormones are one aspect of all the hormones in the hormone systems in the body. And as our hormones change from, as you say, from birth through to puberty, through to adulthood, through to pregnancy, through to perimenopause, all the different phases, those hormones are the ones we can measure easily. There's loads of other hormones that aren't quite so easy to track, aren't quite so easy to measure. And they're all impacted on by many other things in our life, in our existence. There's lots of different factors that contribute. I think one thing that comes from being a bona fide expert is realizing you don't know it all. No, none of us know it all. And the people who make it sound easy haven't worked in the field for long enough, because it's really not easy. And I think that is borne out by saying, well, it's all easy. You just have this hormone and you have that hormone and then it's all fine. And we all know that there are many women who then go, but I've had that hormone and I'm on that hormone and I'm still not fine. And what's wrong with me? And or, actually I'm on no hormones and I'm absolutely fine because I'm doing other things to make sure my well-being is quite right. We are all different. So I think the key pitfalls, I'm trying to make it look too simple and trying to say it's the same for everyone, because it isn't. We're all different, genetically, biologically, from a hormone perspective, from a wider health perspective.
That's a great point, actually, because, I think I'm a great example of that. And I don't want this all to be about me. But just right now, I'll make it about me. Because I have openly had a terrible time through perimenopause. The first 2 years essentially were the worst because I had no idea I was in perimenopause. But we're talking 10 years ago now, and thankfully the conversation has evolved. And, there's information out there. You and I are contributors to that for sure. But I initially went on antidepressants because I was scared of hormones. I'm no longer scared of hormones. I feel like the data's out there to support this as something that's helpful for women. But I had the worst time on hormones, and I tried for 6 years. I think I tried every preparation out there, and I felt worse on hormones than I did not on hormones. And I don't just mean I didn't feel well. At one point, I felt suicidal. Other times, it made some of my symptoms way worse than they were. Vestibular migraines were exacerbated. The hormones would put me in bed for weeks on end. And essentially, the message I was hearing from everyone is that hormones are the answer, And I'm in bed feeling like shit, thinking, oh, here we go, I've failed at something else. I can't even take hormones. And so what do we know? What do we know about that? Like, why are some women so sensitive to?
Because the way we produce hormones in our younger years when we're fertile is very different to how we give back hormones with hormone replacement therapy. So you would have probably been given the cyclical type of HRT when you were in the early days that didn't agree with you. And of course, that gives you a fixed amount of estrogen every day. And it gives you more progesterone or progestogen in the sort of second half of your menstrual cycle. And that is, it's like a very crude replication of what your body would have been producing before you went into that perimenopause. In fact, your progesterone naturally, when you're a younger fertile woman, is only really detectable for a few days every month. And the rest of the time, it's non-existent. It peaks after you get the egg release. So about a week after your egg is released, you get a release from the ovary of sort of a bit of a surge of testosterone, but it's only, progesterone, but it only peaks for a short period of time. And then the rise in testosterone in the second half of the cycle is also, different in different women, but it's not there all of the time. It's there at certain times. The estrogen is low at the beginning, low at the end, peaks in the middle. So many women, I look after women who have premenstrual disorders, premenstrual tension. A lot of women notice not feeling as well when their estrogen's low, in their fertile years. So if you roll on and you're giving HRT, you're not giving an exact replica of what you would have been producing when you were younger. And some women, a bit like any medication, some women will just be able to take any medication and never get side effects. And some women will say, I can't take paracetamol because it gives me side effects.
Actually, you know what? That's me. I can't take anything. I think I'm just like, yes.
So your body is very sensitive to those changes. And clearly the type of HRT you were given was just not agreeing with your system. Your system was fighting it, essentially. That's a sort of simplistic way of saying it. But your body wasn't liking it. And clearly the estrogen, it's usually a higher level of estrogen that causes the migraine type symptoms. So you may have just had a bit too much estrogen for what your body wanted, or, too much at certain times. The progesterone may not have been agreeing with you, or the progestogen, and so that's probably, as well as I can say, it's not reproducing exactly what you have in your younger years. And even for postmenopausal women, when we give the sort of continuous combined HRT, the progesterone that's there in the preparations continuously, a lot of women don't like it. And I think a lot of women rate natural progesterone in the more modern formulations better than some of the older type of synthetic progestogens. But I see a lot of women who go, can't take it, don't like it, don't like
that. Was me. I tried every type of progestin, and Manera coil, vaginal. It just made me feel terrible. And so after I sort of tried everything, I even tried something that we can get in Canada called Tibolone, and I don't know if you can get that. And you can, and it's another form, as you know, of HRT. And in the end, I just was like, you know what, like I'm actually post-menopause now and I'm fine. I'm fine. And I think that that's something that I've really learned to appreciate in it. And I'd like to touch on this with you because of your personal story, is that, you know, HRT didn't work for me. It doesn't work for some women, yet they feel like they're failing. And I'm trying to say to them, hey, it's not for everyone. We're all unique. And so please, you know, if you're suffering, there's other things you can try as well. But essentially now I'm 51, nearly 52, and I feel great. I'm on no hormones, and I don't have this idea that I'm going to die young, that, you know, that I'm going to have a heart attack or my bones are going to break. Like, I feel like I'm so tired of the doomsday scenarios that I've been fed through perimenopause that I'm just like, God, let's just stop that. Let's just be brutally honest about what it's like living in a body without hormones and the things that we can take control of. And so based on like my experience, like feeling good on no hormones, for sure there's some challenges, but you know, I can learn to like deal with sleep issues and etc. Can we talk about you and what happened to you from a personal perspective from your breast cancer diagnosis, and sort of like how that's forged? It literally has forged a path for you, hasn't it, in the conversation about menopause in such a positive way. And I think that's why I feel so connected with you, because you've become vulnerable, but also solution-based. And women see that and are like, oh, hell, Annice.
Well, I mean, so just to go back, a couple of things you just said before I go to my story. You said, you know, you've got no hormones, I've got no hormones. But actually, see, as an endocrinologist, I know we've got plenty of hormones. We've got adrenal glands that produce lots of androgens and estrogenic and progestogenic steroid type hormones. And there are other compensatory mechanisms in our body and other hormone systems that balance your hormone narrative in a way post-menopause. They compensate for the deficiency in the fertility hormones. So when you say no hormones, the hormones that we measure that we know are associated with fertility are gone. In fact, even when we give those back with HRT, the fertility doesn't return. We're just giving back those specific hormones. So we're not totally hormone free. We haven't got the ovarian hormones. And then the other thing that you said about women, you know, it's so true. Women feel terrified, particularly if they don't agree with the HRT, because at the moment we've got this pendulum. The pendulum in 2000 was let's give everyone HRT forever. And then 5 years later, it was let's give no one HRT ever. And now we're going back to everyone has to have it whether they want it or not. And it's sort of like this swinging pendulum that needs to just get into the middle ground, because some women cannot manage without HRT. And I see that in my clinics, and I see some women who cannot take HRT. And I see many women who take it for a few years and it's fine. And then they start to find it's not working as well for them and they stop it. And a lot of women, I think at the moment, who are maybe in their 40s and early 50s are thinking, I'm never going to stop it. But I've seen equivalents of those people over many years, and their story may be different in 5 years, 10 years, 15 years. So we have to, I think, accept our bodies change, our needs change. And I don't want women to feel terrified if they can't take HRT because of the narratives that are being portrayed in the media. And it doesn't, if you can't take HRT, it doesn't mean you're definitely going to get osteoporosis, you're definitely going to get dementia, you're definitely going to get heart disease. There are many other factors that contribute to.
So can we as women live post-menopause without the fertility hormones, healthy and with longevity? Can we? Yes or no?
Yes,
Good.
absolutely.
Okay.
But it's not about, so if you take HRT and you sit on the sofa and you eat McDonald's and you don't stimulate your brain, you know, and you don't move for the next 40 years, you're not going to be healthy at 90. In fact, you probably won't get there. And if you don't take HRT and you do regular exercise and you do your Sudokus or your whatever it is that intellectually stimulates you, and you do your, have good nutrition, unprocessed, you have laughter, you're not stressed, all of those things, you can live a very long time without those fertility hormones. There are genetic factors that contribute to our longevity. that are beyond all of our control. So if you've got a strong history of heart disease, you need to work on whatever's needed for that. If you've got, other health issues, you need to work on those. So it's not binary. It's kind of very, very, it's a matrix, isn't it? It's basically...
It's not binary. It's so great to have this type of conversation because it's sorely lacking. And I know that you and I often feel like we're stepping out of like the mold by saying these things, but we're really being very practical and pragmatic. I feel like we're not saying anything that, that's offensive in any way. I feel as though that our message often gets looked at as being the odd one. Anyway, I really want to hear about your mind sharing? Yeah.
Oh, sorry, I was digressing. So
we both do.
At that point, I'd been a hormone specialist for about 20 years, and I had specialised. I'd done a lot of work looking after women who had had breast cancer and then had had early menopause in various situations, and also younger women who'd had other forms of cancer, because I'd worked at a big cancer hospital in the UK, both when I first qualified and then later on when I did my research. So I had a huge specialism in looking after women with early menopause, some who could take HRT and needed it, some who couldn't take HRT safely because of estrogen positive breast cancer. And I've seen all the research, all the balanced research on this topic. So I'm not looking at one study and saying, well, I think actually let's just follow that particular. I look all of the research and you work out, what's right for women, what's safe for women. And so I'd seen all of that, and I'd helped many, many women already at that time with managing complex, difficult menopause. And also many women who were on HRT, but still not quite right. Because, I have been in this game a long time. Not everyone is feeling great with HRT. I see a lot of patients who aren't great with HRT. So I'd had all that experience. And then one day I thought something had happened. Somebody had had some health issue. And I thought, I haven't examined my breasts for a while. So I decided to, thinking, I'm healthy, I'm slim, don't drink, don't smoke, no family history, not really worried. And then I found this lump in my breast, and I just thought, I don't know what this is. It's probably nothing. I don't know whether I'm going to bother with doing anything about it. And then I got my husband to examine it and to have a look. He's actually a doctor as well. So I thought, well, you just have a feel. And he said, I think you need to go and see the breast surgeon. And he was quite stressed. And I'm biased, but he's a very good doctor. He's a lung specialist. So, he's a very experienced doctor. So he was worried. I wasn't really worried, actually. I just thought, no, there's no way I'm going to have that, because,
Which is often what women do, isn't it?
Denial. It's a great thing. It's a great denial. So I didn't think anything of it. But anyway, we got seen very quickly because I work at a specialist hospital. It was my colleagues, and they were like, right, I've got a cancellation, come in and have your mammogram and assessment. And literally, I just carried on working. I went for the mammogram, went back to work. The next day I was in clinic, finished my clinic, and my husband called me, and the surgeon had said that she wanted to see it. We had an amazing female surgeon. She said she wanted to see me in her clinic that day. I thought, it's not great. And she'd already said to me she was 99% sure it was nothing. And then she calls me in, and anyway, it was cancer of the breast. And then I'll speed forward, because unfortunately I then went for a scan to look at the lymph nodes. And when the radiologist was looking at the lymph node, she found another cancer. So in the end, I had very early stage breast cancer, but I had two separate primaries.
And how did you emotionally cope with that? Were you horrified?
I think shell shock is pretty much what you feel. You're like in an international transit lounge. You don't relate to anyone at all in that moment. And, I had a lot of experience at that time, but I had young kids. I had kids 7 and 10, and or thereabouts. And I was terrified. I didn't know what was going to happen. But then I wasn't hysterical. I didn't really cry very much, actually. I mean, I think I cried a couple of times, but I was just like, I don't know. I just don't know what to do. And it was also this whole, why would I have two cancers in the same breast? I don't understand that. So I then went for surgery, and I had to have quite extended surgery because there was two of them. So I had to have the axillary node clear of the arm, sort of lymph node removal and mastectomy and all of that. And so that was almost easier because we could right, we know what we've got to do. And then we had to do more tests to see whether I needed chemotherapy. And so that first bit is the worst bit, shell shock. Then it was like, wow, the stats are really good. It's a really, early stage. It's a low grade, which is good. You always want low grade rather than high grade. But then I was thinking low grade means it can come back 10 years later rather than, if you survive 5 years, it's gone. So
it's like the more you know, right? Unfortunately for you. Yeah.
And at that point, it was problematic. I was reading everything and working out what management to have. And they basically said, we don't think you need chemotherapy because you've had a good clear margins. They'd removed it all. The lymph nodes were clear. It was a low grade. Both the cancers were relatively small. I think they were both around 1 centimetre each, so relatively small. But of course, there was 2 of them. So how does that, because that's 2 centimetres, it was really difficult because although it was what you call multifocal breast cancer, usually they're more advanced or aggressive. So it was a lazy, slow growing, but multifocal. It was difficult to know what to do. Anyway, they said no chemo. And it was then that I said, well, I want to be belt and braces here. I look after women in menopause. I'm not scared of going into menopause. Frankly, I've been telling women how to do this for long enough. I'm not scared of it. And I thought, actually, it'd do me good to know what my patients feel like. So then they ended up putting me into like a chemical menopause, which is where they give you injections to shut your ovaries down totally. So it's a little bit like having your ovaries removed, except it can be reversible. So they give you injections. I had them for about 2 years. So by the time they said, look, stop them now because you've had 2 years of ovarian suppression, they call it. And then I basically was postmenopausal.
Anyway, yeah. Is that the tamoxifen? Is that something different?
No,
that's medicine, isn't it?
It's chemical menopause, so it's injections, Zoladex or Prostat, which I often use for this. They use for other things, but it's a chemical menopause. And then I also had tamoxifen as well. And to be honest, so my whole story is like on its head compared to what other people experience menopause as, because I was like, I had cancer. I wanted that cancer gone. I'd seen so many women die of breast cancer when I was a junior doctor in the early 90s. And that was because they didn't have the options that I had. They didn't have the tamoxifen and the Zoladex. We didn't have all the knowledge that we had in 2011 when I went through breast cancer. So I wanted belt and braces. I just wanted to be menopausal. It seems crazy now, isn't it? When you think about it. And I also had the knowledge. So when I started having my hot sweats, which came about a week and started bursting into tears, a week after I had my first injection to switch my ovaries off, I was just like, I was really happy. I was like, great, because my estrogen level is really low, because it's your own estrogen that feeds the breast cancer cells when they're estrogen positive. So all this talk about, well, if you have body identical estrogen after breast cancer now, then you're all right. It doesn't make any sense because it's your body's. I saw those women in the 1990s. They all died of breast cancer because there wasn't tamoxifen. There wasn't all this aggressive surgery. Chemotherapies weren't as good. And it was their own estrogen that was driving the growth. So anyway, I just wanted my own estrogen flat as a pancake, which we did. We achieved it. So, and then I just used all the techniques and tweaks.
Right. So now you're at the stage where you're like, I'm full-blown menopause. I'm going to throw the book at this, right? And that's sort of like my attitude to stuff as well. I didn't have the trauma that you went through. I'm sorry to hear you went through that, but it was similar in the way that, what can I do? I'm going to throw everything at it. And that's where our worlds align for sure. Yeah. So how we're sort of coming nearly towards the end, but can you sort of tell me the type of things that really helped you from a physical and emotional standpoint? Because typically the emotional or even neurological side of menopause can be the more challenging, right?
Well, it almost took the fear away for me. So I wasn't fearful of menopause. I thought menopause was my ticket to survival. So it's a funny one, really. I wanted to be in menopause and I wasn't afraid because I know all the data on cardiovascular disease, for example, and early menopause. I've looked after many women with premature menopause and some can't take HRT, for various reasons. So I knew that I wanted to mitigate any cardiovascular risk. The best way to do that is moving. Moving also helps protect your bone health. health. So exercise and movement. And I wasn't very, very physically active before I had breast cancer. I had 2 young kids. I was refurbishing a house, working full time, writing up my MD thesis. I didn't do a lot of exercise. So I built up.
And I just tell you that Annice is a doctor who lives, by the way. She's a strong doctor. I love it.
But I built that up over the last 10 years, and very, very slowly. So when women say I can't face doing exercise, I understand that, because you can't just suddenly do what you do, for example. No one can do that. And I think, wow, I can do, all the press ups and all of that. And I remember when I started, my shoulders were so weak. I couldn't do anything, but I just tried and did a little bit and just built and built and built gradually. So movement was a big thing. And also the thing about exercise is it takes your stress away. It's distracting. It's almost mindful. So I'm not very good at meditating. I tell all my patients to, and I always say, I'm useless at it, but it's really good for you. And if you can't do it, everyday mindfulness. And one of those things, walking outside, exercise. When I go to my classes, and you'll be the same, you can't be thinking about something annoying that you've seen you're so focused on that exercise, and it's brilliant for stress relief. So exercise ticks up so many boxes: your cardiovascular protection, your weight management, your osteoporosis, your bone health, stress management, all of those things. It covers them all. And then, trying to stick to unprocessed foods, it's difficult in the modern world because processed foods everywhere, but being just conscious to keep your nutrition, to try and keep all the good stuff in, rather than, trying to say restrict yourself. And
yeah, I know that here in the US, they tend to refer to them as hyperpalatable foods, because all food is sort of processed in some respect, apart from like an apple off a tree, I suppose, unless that's gone through some cleansing thing. But the hyperpalatable, I think you're referring to like the stuff that's got extra added sugar and fats and salts and the things that are produced to make us want to eat more with no nutritional value, right? I know what you're referring to. Yeah.
But whole foods, nuts and seeds and lentils and, vegetables and fruit, they are whole foods. They are not processed. I mean, you can cook them, but okay, if you're having a tin of tomato, adding a tin of chopped tomatoes to sort of some meat or something in a casserole, okay, that's kind of partially processed.
No, you're not demonizing that. I realize that, yeah, for sure. It's just
it's the ultra processed stuff that it's a lot of the wheat based stuff. So bread and pasta, which I completely accept is, in moderation, is fine, but we tend to eat too much of all that stuff because it is easy to overeat. So, I mean, I'm trying to keep that right, but I'm not a nutritionalist. I try and keep it simple. And we all like a bit of sugar now and then, especially if you're doing exercise. So, but just trying to just be mindful about the really bad stuff that's very ultra processed and sleep. Well, sleep's my big.
Yeah, so I know sleep's your thing, right? So like, and we've talked about this on one of our Instagram lives out, how hard it is for the changes that you make to improve your sleep to show up. Like they take a long time. Sleep hygiene takes a long time to like actually show up as being successful, doesn't it?
Oh, really does. And I think mine didn't help because when I was a junior doctor, I did really long shifts, and we didn't do what they do now, which is they'll do nights and then days. We just had to stay in, and we were resident, and I used to have to go and sleep in a little room, and I'd get called all through the night sometimes. So it was very disruptive, the sleep, when I was a junior doctor. And so I try very much to keep to a sleep routine. But also, I think the other really important thing about menopause is we also have to live. We have to enjoy our lives. So, I like going out with my friends for dinner sometimes. I like having a glass of wine sometimes. I like, having a late night sometimes when I'm, in my friend's house dancing in the kitchen, which we did the other weekend. You also have to live and laugh as well. And that is hugely important. And going back to that, your social network, because isolation is not good. It doesn't matter. All of these things, they might seem not important, if you're just looking at one particular thing, but social network is I think hugely important.
Well, look at the blue zones around the world. I mean, one of the criteria for the people living as long as they do is community-based living, isn't it? Just having lots of friends around you and talking and laughing, and it's huge.
It is.
Especially because menopause is, I felt, and a lot of people do, an isolating an isolated place to be, right?
Yeah. And I think that is why at the moment, although there's a lot of confusion amongst women because of social media and lots of people having different opinions, the great thing is I think a lot of women realise they're not alone because they're seeing everyone else having similar themes of concerns and things if they're looking at social media. So the fact that we're talking about it is a really positive thing because you feel less alone, I think, as a woman.
You totally do. And I remember reading a research study, and I can't find it now. It was when I was writing my book, and it literally spoke about women with vasomotor symptoms, so the hot flashes, cold sweats and things like that, how the symptoms actually reduced and the burden was lessened by having a support network and by it was a workplace talk, and by talking to somebody within their employment. And it was something like 60% reduction in hot flashes by just understanding that this work, because it does come from the brain, right? Like it's all about our perceived temperature. And I just was like, so talking and having compassion, having empathy and having, strategies in place can help the symptoms reduce. I was like, well, that's cool and that's free, right?
Yes. And it's hard to understand. It's hard to a lot of women who are struggling, they go, no, that's not going to help. How can that possibly help? It's not a pill, it's not a potion, it's not a gel, it's not a cream. But it does. It's hugely powerful. Yeah, those things. Yeah.
So as we wind up this interview, and I don't really want to because I could talk to you all day, we've just spoke about how the menopause conversation has shifted and the pendulum swings back and forth. And it's a really good analogy from me in Canada watching the UK in particular. But I also think that we've come a long way in a positive way. We're talking about this. It's a normal conversation in my household, in your household too, right? It's evolving as we can see. In your opinion, what would you change about the menopause conversation and where would you like to see the menopause conversation go moving forward? It's a bit of an ambiguous question, but I just think that I'm really interested to see how this evolves and how you would like to see it evolving.
Well, I'll answer that question based on what I know. So it might sound almost arrogant, but we are all different. Every single woman's menopause experience is different and what she needs is different. And what I would like to see is the menopause conversation to be more inclusive rather than almost combative, almost in groups. I'm in this camp and I'm in that camp. I'd like to see us all celebrate each other's rights to choose our own path for menopause. And if we choose one path, and somebody else chooses another path, that's absolutely fine because there isn't a right and wrong. And what's good for one person is not good for another. And I just want to see women understand that what might work for them might not work for somebody else and vice versa. But I think overall, it's going in the right direction because we're talking more about it. And I think that will naturally come with time.
Yeah, well said. What a great way to end the show. I really appreciate you joining me for this first episode. You're a gem. And if anybody wants to find you, what's the best place to look?
Okay, so probably on social media, on Instagram. I'm there. I'm obviously linked with you a lot as well on Instagram, but I'm the Hormone Doc. And if you put my name in, I'm over in the UK. And generally, other than that, I've got a website and things like that. And I've got my book, of course, as well. So if people Google, they can see all about what I do. I do lots of different things. I do a lot of educating doctors and other things as well.
And also, I will link to the book in this episode and it's on my website too if anybody wants to try and find it. So thank you so much. And thank you, everybody, for joining me today for this first episode. I very much appreciate it and I hope you stop by for more. Thank you. Bye for now.
Thanks for having me. Bye.
Thank you so much for listening to the show. If you like what you hear, then why not subscribe to this podcast and leave me a review? You see, when you do this, it helps to raise the profile of my show and attract new listeners. And it also allows me to continue to deliver valuable content with great guests. And in return for you doing that, I will send you my 12-week core-focused program called Abs on Fire as a thank you. Simply drop me an email at amanda@amandasteve.com and I'll wing that your way. Bye.